Great, thank you so much. So we'll start with chest. I have an hour, so we'll spend half an hour on chest and half an hour on musculoskeletal. Some of these cases are very simple. Two or three of them were shown yesterday, so it's just a question of finding out whether you all were awake or not. And most of the times, the diagnosis is there in the history. Some of these are spot diagnoses, some of them you have to look at the story and kind of come to a specific diagnosis. So here's an 18-year-old pediatrician's daughter who presents with cough and expectoration. And among other things, this case tells us for sure that irrespective of who you are, once you, as a pediatrician, once your child, is more than 12 years old, you need to make sure that some adult doctor gets to see your own child. Second thing, of course, is you should never try and treat your own child as well. So what happened is, this is about 7 or 8 years ago. She comes with cough and expectoration. They do this radiograph. They find a lesion in the right paracardiac region. And the pediatrician's thinking is that what happens in a 9-year-old, when you see something like this, maybe with hilar fullness, it's TB in India. There's nothing else to it. So he puts her on anti-TB treatment. 3 months later, this is what happens. There's a lot of this cystic change with fluid levels, and the size is increased, and he freaks out completely. Now, instead of going to an adult physician, he gets a CT scan done from his cousin brother who runs a CT scan center. And this is what they find on the CT. And the brother thinks perhaps this is a malignant tumor in an 18-year-old. So again, instead of running to a physician or an oncologist, he goes to a chest oncosurgeon straight away. And the chest oncosurgeon looks at it and says, you know what, maybe I think I have something in my mind. So he calls me and says, can you prove the diagnosis? And I said, yeah, I'd like to repeat the CT, do the contrast properly. He says, no, you can't do that. I said, why? Oh, because it's the cousin brother who did the CT scan, and if you repeat the CT, then the pediatrician will think that his cousin brother is not a good radiologist. So I said, fine, we'll do an MR. Here we are doing an MR for a focal lesion in the lung. And whenever we do, and I mentioned this yesterday, or day before, that whenever we give contrast in MR anywhere in the body, you also do a dynamic contrast study. It doesn't take away anything from the study, but almost always adds something. So you have a coronal and a sagittal MR. We went ahead and did the contrast. So you see the arterial phase study from this. It was just there, and so we kind of did that. And these are your choices. Is the sequestration, pulmonary blastoma, hydatid cyst, or amoebic abscess? Your time starts now? Yes. So you can just make sure the stuff is working. You've got 10 seconds. So the aim in this game is to get 100%, right? That's what we're going to aim for in one of the cases. That means that I've won. Yeah. Well, we almost reached there, didn't we? So this means that Erica's lecture yesterday was successful. Great, right? So everyone got that. And if you just go back, that's a paracardiac lesion. The way to diagnose sequestration, and what typically happens is these patients, it takes a median of about 1.5 years or 2 years from the time that the patient first presents to a doctor to the diagnosis getting made. And it's not rocket science, but nobody thinks about it. And the person who makes the diagnosis is the first person who's actually just thought of it. So the first person who says, could this be sequestration, then actually gets the imaging done for that, or looks for the abnormal vessel that we see here arising from the celiac axis. It's usually done on the CT scan, and Erica yesterday showed lovely images of those with 3D CT angio, etc. And then the diagnosis gets made like this. It's like frozen shoulder. it takes 9 months for it to heal, irrespective of what you do. The last doctor to whom the patient goes gets all the credit. It's similarly here. The first person who thinks about the diagnosis eventually makes the diagnosis. So this was sequestration. The next question I would want to ask, and this is just an open forum, is this intralobar or extralobar? Anyone would like to shout this out? Yeah, well, one of the ways to differentiate is to look at the venous supply, drainage. And if the venous drainage is into the pulmonary circulation, then often it implies that it's intralobar, whereas if it goes into the systemic circulation, then it's usually extralobar. So that's one way of differentiating it, and this was intralobar sequestration. Okay. This is the second case, and this is a 17-year-old with gradually increasing breathlessness. We saw this case yesterday, but again, it's just to figure out whether people were awake or not. So 17-year-old with gradually increasing breathlessness, that's the chest radiograph. It is considered to be a spot diagnosis, and these are your choices. A, alveolar proteinosis, B, microlithiasis, C, pulmonary edema, and D, ARDS. And your time starts now, just about. Okay, now. So we got 83% right last time. We should hit for 100%. 100. The problem is somebody invariably presses E, right? But there's no E, but if you want to mess this up, you press E, and oh well, great, we got 83%. How's that possible? There's only, B, right, and there's some A, fine. So it is alveolar microlithiasis. You can see that here, very high density material that is present within the lungs. That's the CT scan here that shows the dense ossification that infiltrates into the lung parenchyma. This is the CT is different from the one I showed you yesterday. And you can see these so-called paraseptal cystic lesions that don't really exist are actually an optical illusion because of the dense ossification that you see here. So this is alveolar microlithiasis. Almost all these patients have a certain age group and have progressive breathlessness. So some of them don't really give you much from the history. But this is a very interesting case. It's a single image, but there are multiple findings on the image that should be able to help you with the diagnosis. So this is a 33-year-old girl who has progressive breathlessness. This is a single HRCT of the lungs. Clearly shows findings within the lungs, and then something else. And that's the something else that should help you make the diagnosis. So what are your choices? Your choices are A, scleroderma, B, rheumatoid arthritis, C, SLE, and D, asbestosis. And I'll show you the image once again here, and your time starts now. Great. 15 seconds. And I'll show you the image once again. Two findings, both of which help you make the diagnosis. Great. Okay, so we're doing really well. This is a this is honeycombing. Honeycombing equals to the usual interstitial pneumonia pattern. Now, when I said yesterday that the UIP pattern equals IPF if you don't have an identifiable etiology. But in a 33-year-old, when we see a UIP pattern, almost always there would be an identifiable etiology. Now, we have scleroderma, RA, SLE, and asbestosis. Asbestosis clearly is out because you wouldn't have had enough time for exposure, and women typically don't have asbestos exposure to this extent. So you have the first three to deal with. What is it on the CT scan that tells you this could be scleroderma? There's esophageal dilatation, which typically occurs with scleroderma, and that is how we have a diagnosis of scleroderma. Otherwise, this could be RA-related UIP pattern, it could be SLE-related UIP pattern, or it could be scleroderma-related UIP pattern. Just by looking at the UIP pattern, we wouldn't be able to differentiate among the etiologies, but the esophageal dilatation helps. So that's scleroderma, and I think we should really give ourselves a good hand. So that's nice. Anyway, the next one. 35-year-old man comes with dyspnea and fever, and the chest X-ray shows bilateral small pleural effusions. Here's the CT scan through the upper lobes. Please look at it carefully. There's a specific sign that we see here. That's the CT scan through the lower lobes. And again, we see something very straightforward. That's the contrast enhanced CT. And you again see a couple of interesting findings. And these are your choices. This is lymphangitis carcinomatosis or lymphangiomyomatosis, pulmonary hypertension, or pulmonary edema. And I'll run through these images again. Upper lobes, lower lobes, contrast CT, and these are your choices. Your time starts now. We saw a similar case yesterday, but let's see if this works. All right, great. So 40% get D, because it's kind of split between A, B, and C. If we look at lymphangiomyomatosis as a choice, this doesn't really exist because that's a cystic lung disease. Pulmonary hypertension by itself would not present with this spectrum at all. So if at all, we're left to differentiate between lymphangitis and pulmonary edema. We have septal thickening that is bilateral and symmetrical, and it's non-nodular. When we see this appearance of septal thickening, you're right, we have two choices, lymphangitis and pulmonary edema. We also see bilateral effusions. Now, it's very unusual to get bilateral effusions in a patient with lymphangitis. Not only that, yesterday I told you that in the absence of a known primary anywhere in the body, you shouldn't actually be thinking of making a diagnosis of lymphangitis. So bilateral pleural effusions associated with septal thickening, that's a classic appearance that we would get with pulmonary edema. Not only that, the etiology of the pulmonary edema is there on the scan. Anyone would want to talk about that? We also know what the cause of the pulmonary edema is. So here we see a mitral plug. This patient is a known case of mitral stenosis, operated in the past, clearly has got restenosis, the left atrium's dilated, and that's how the patient has left-sided failure with pulmonary edema. Okay. The story helps in this case. This is a 70-year-old man with arrhythmias who comes with sudden breathlessness. That's the CT scan. You have an HRCT axial, that's a coronal. This requires a little lateral thinking, but again, 70-year-old man with arrhythmias comes with sudden breathlessness. It's actually dyspnea. On the right side, there are Velcro rales on auscultation and fever as well. So these are your choices. A, invasive aspergillus, B, vasculitis, C, BOOP, and D, pneumonia. I'll show you the image once again, and these are your choices, and your time starts now. 70-year-old man with arrhythmias comes with dyspnea, fever, Velcro rales, the CT scan appearance, and these are your choices. Okay, so again, everyone's getting the right answer, but the percentage keeps kind of fluctuating at about 40 or 50%. If you look at the CT scan, we have peribronchovascular consolidation. Now, this could be anything. It could be a resolving lobar pneumonia or a segmental or a subsegmental pneumonia, but it is consolidation. And in the setting where the patient seems to have interstitial lung disease, and I mentioned this yesterday, consolidation as an interstitial lung disease occurs with organizing pneumonia pattern. So that's your BOOP pattern or your bronchiolitis obliterans organizing pneumonia pattern. Our other choices were pneumonia, which is a possibility. Vasculitis, small vessel disease can also do this. Invasive aspergillus typically occurs with an immunocompromised individual, not HIV positive, but related to other issues, and our patient clearly doesn't have that. So anyone, how does the arrhythmia part set in here? How does that fit in? What happens to patients who have arrhythmias, and why would they get BOOP patterns? So patients with arrhythmias are most commonly treated with a drug called amiodarone. And amiodarone, the commonest lung complication that amiodarone presents with is a BOOP pattern. So you have a BOOP pattern because of amiodarone, and that's essentially how we have this diagnosis. So very nice. We got that right in a good way. The sixth one, we have a 32-year-old who comes with breathlessness and fever. This is the HRCT image. We have a single image here, but this is also considered to be a spot diagnosis, right? Fever and breathlessness. If you remember yesterday, I mentioned this is a combination of findings that is not very common clinically, and it generally implies two conditions, right? So here's the HRCT, and these are your choices: sarcoid, tropical eosinophilia, metastases, and tuberculosis. And show the image once again: fever, breathlessness, and your choices. And your time starts now. Sarcoid, tropical eosinophilia, metastases, and tuberculosis. Oh, brilliant. That's about 60% people getting D right. Do we also get a sense of how many people have voted? Where is that? But that's, oh, so you still have to total it mentally, isn't it? So that's 7 and 9, 16, 18, 27, 37, 46. So we've got about 150 people in the audience, right? Why would we have only 50 people voting? So why do people not have the clickies? The remotes. I thought there are 400 remotes, right? Okay, so we're going to take a break for a minute, right, and get everyone to have remotes. Can you please organize? Yeah, but I think, can we just, nobody here in this section has a remote.
Excuse me. Excuse me.
No, you keep the remotes because you also have to vote. Okay, so while that is happening, let's just look at the image. What we have are 2 to 3 millimeter sized nodules that are randomly distributed throughout the lung parenchyma. This is very, very typical of miliary disease or miliary nodules. Now you can get miliary nodules with sarcoidosis and with metastases and with tuberculosis. Metastases are rare in a 32-year-old without a known primary. Sarcoid would have other kinds of nodules associated with this. You actually also have a discrete larger cavitated nodule, and this combination of findings would be most commonly seen with tuberculosis. Tropical eosinophilia does not present in this manner at all. So that's essentially what we have. Great, so we've got more remotes. So now we need to get to about 75 or 80 people answering. And I'm going to count now for the next one, yeah? Great, so we move on to the next one. I'm going to increase the speed a little bit because It's already 6:40 and we still have MSK to do. So we're going to go a little fast and then see how we can finish these. 64-year-old lady comes with acute breathlessness. That's a contrast enhanced CT that we see here. I'll keep this on for about 5 seconds. This is one of those situations where you don't even need to be a radiologist to make the diagnosis. This is where the technologist or the first year medical student or anyone can look at this in the correct clinical setting and get this, right? 64-year-old lady, acute breathlessness, conventional contrast enhanced CT scan. These are your choices: sarcoid, carcinoid, SVC syndrome, and pulmonary thromboembolism. Your time starts now. Great. So this is where we start voting: sarcoid, carcinoid, SVC syndrome, pulmonary thromboembolism, and that's the image that we have. So this is one of those where 100% would be nice, but let's see how many people actually vote in. And we actually got there, 95.5%. And we have 88, 89, 90 people answering from less than 50. So that's a great thing. Is there anyone else who needs a remote? We can still have a few more of them circulated to make sure that we have more and more people. So here, I don't even need to go through the choices. There are filling defects here in the pulmonary arteries. Why did I say this is a straightforward diagnosis? Because really it's a binary all or none phenomenon. If the pulmonary arteries are opacified, anything that is black or gray that is not as white as the contrast is a filling defect. In a patient with acute breathlessness, this is pulmonary thromboembolism. You know, you have paradigm shifts in medicine, right? When you had the first ultrasound showing the fetus, you had MR showing the cord. This too, basically, the ability to pick up pulmonary thromboembolism non-invasively with a contrast enhanced CT to an extent has completely changed the way we deal with this field of medicine, completely. So it's a big deal in terms of the ability to make the diagnosis. And you have other ways. You have plaque thrombi, you have them completely occluding the vessel. You see, you also have to look at the right ventricle, the pulmonary artery. You can do these reconstructions. But at the end of the day, a filling defect occupying the vessel is pulmonary thromboembolism. 8th question, 46-year-old comes with breathlessness. This is a classic radiology question. And in the long case, if the radiology resident appearing for the exam doesn't get this, he would fail. Consultants need not get it. Consultants don't need to know anything. But the radiology resident needs to. This is very important. This is an HRCT of the lungs. You see this really well. And I will again say it's a 46-year-old woman, who comes with breathlessness. There's one sign here. That is classic radiology. If you get it, you have the answer, your choices: sarcoid lymphangitis, pulmonary edema, and alveolar proteinosis. The image once again. Please move ahead, and your time starts now. Sarcoid lymphangitis, pulmonary edema, and alveolar proteinosis. One sign that gives you the diagnosis. That's all that you need to do that. That's the image. These are your choices. Okay, so we tie up between sarcoid and lymphangitis. The sign, anyone, the one that we're looking for? Mastectomy, right? You have evidence of a mastectomy. Once you've got that, you know that the only reason somebody would knock a breast off is if you have carcinoma breast. And here you see nodular septal thickening that suggests lymphangitis, discrete nodule, which is an associated metastatic nodule. So clearly we're dealing with lymphangitis. The other choices don't even really matter in this setting. 51-year-old man working in a samosa or a sambosa factory, right, presents with dyspnea and cough. That's your chest radiograph, looking really ugly, but that's the history. Samosa factory presents with dyspnea and cough. And these are your choices: asbestosis, berylosis, silicosis. You didn't expect this, right? You thought it must be lymphoma, bronchoalveolar carcinoma, etc. But here's where we are: asbestosis, berylosis, silicosis, or barretosis. This is the radiograph, And let's move on with the question. These are your choices. How does a person working in a samosa factory get one of these? And which one would you get?
Sambusa.
Samosa factory, samosa wrap factory. Sorry? Samosa, I've
The
been
same like
having
sambusa,
samosas in
sambusa.
Kuwait all the time, so I would
Yeah.
assume everybody knows what they are, right? Shafiq, no? That sambusa, yeah, it's a sambusa factory. Sambusa. Yeah, that's fine. That happens in India as well, all over the world. You have all kinds of stuff inside. Okay, do we have an answer? Okay, so everyone who answered, let's see what happens. So this is a very Indian thing that we had, but I will show you the CT scan, and maybe that helps make a diagnosis. This is the HRCT showing nodules of different sizes, confluencing into areas of consolidation that essentially represent progressive massive fibrosis and eggshell calcification within the lymph nodes that would suggest the presence of silicosis, right? So eggshell calcification is an extremely important clue, but the entire constellation of findings is highly suggestive of silicosis. So the question is, how does a worker working in a sambusa or a samosa wrap factory in India get this? It's a very interesting story. So this patient came to the OPD in one of our public hospitals. We looked at the CT and we said this is silicosis. And you never make a diagnosis of silicosis in a patient de novo. The patient invariably comes and tells you, I work in a mine, I have that disease that people get when they work with silica or coal mines, etc. And here, one of the doctors actually accompanied the patient to the wrap factory. Now, you know the samosa leaves, they're made of flour. And what happens in India is they make packets of about 20 leaves. Each of those leaves has to be separated from the one below, otherwise they would get stuck to each other. These days you do it with foil or some amount of aluminium or plastic or whatever. In this particular setting, they were doing it with sand. So you would have one leaf of that sambusa or samosa, you sprinkle sand on it, then you put the other one on it, sprinkle sand. So the sand would prevent the leaves of the sambusa or the samosa from sticking to each other. And you had these men sitting in ill-ventilated rooms with a bowl of sand, doing this 8 to 10 hours a day, 6 to 7 days a week, 50 weeks to 52 weeks a year, 10 years, and everyone in that room had breathlessness and disease. So that was one of those weird things where we had to do detective work to find out that this patient had silicosis. 10th question. 66-year-old man comes with progressive breathlessness and one episode of hemoptysis. There are 3 questions in this case, one after the other. So we look at it in that sense, right? 66-year-old man, progressive breathlessness, one episode of hemoptysis. That's the HRCT image. Very, very characteristic of what we were talking about yesterday when I started the interstitial lung disease talk. This is the image in the upper lobes. That's the image through the mid-zone, and you already saw the basal image. Your choices: UIP pattern, NSIP pattern, BOOP pattern, or cystic lung disease. And the your time starts now. So there'll be 3 questions. The case will develop as we go on. Here's the basal image: upper lobe, middle lobe, UIP, NSIP, BOOP versus cystic lung disease. Great. So we have equally distributed among the 3. This is honeycombing, right? Very layered cysts stacked upon one another. It's just that it's unilateral, and that's what's important about the case. You actually see honeycombing even in the upper lobe. So if you have honeycombing, it's a UIP pattern. That's pretty much it. So this is the UIP pattern and not NSIP, BOOP, or cystic lung disease. Then we had the contrast enhanced CT done because we saw other things. And you can see the image here just below the carina or below the tracheal bifurcation. And please look at it really, really carefully. So that's your contrast study. Here, a little further down as well, and still further down. Contrast enhanced study to accompany this patient who has a UIP pattern. And we then ask the question, where do you work? And he says, I work in a brake lining factory. In fact, his daughter was a doctor, and she would consistently refuse to give us the history, thinking that we would have some divine intervention and all this stuff would come into our heads. But we kept asking because we saw something on these images that made us ask this particular history. And he told us he works in a brake lining factory. What is the cause of the UIP pattern in this patient? Silicosis, asbestosis, berylosis, or stenosis, and your time starts now. He has a UIP pattern, classic honeycombing. It is unilateral, and these are your choices. Okay, and I think the majority got that right. So brake lining factory, classic history for asbestosis. But if we got this right, we also find that the patient has pleural calcification, which is very characteristic of asbestos exposure, and therefore clearly the patient has asbestosis. Look at the image again. There is something more that the patient has. So the patient has a UIP pattern. It's asbestos related, and patients with asbestosis are known to have superimposed complications that can occur as well. And we see something here that's more. What is this? Tuberculosis, carcinoma, either of the above, none of the above, and your time starts now. Here's the image, and these are your choices. TB, carcinoma, either, none. Okay, so it's TB or carcinoma, and then 1/3 said either. The point is, I don't think when we look at the focal lesion in the lower lobe, we would know whether this is carcinoma or whether this is infection. And the only way to be able to do that would be to stick a needle inside, or if you have a very aggressive pulmonologist who's able to reach up to here, then a bronchoscopy guided biopsy. So we did the biopsy, and it did turn out to be adenocarcinoma, but the correct answer would be C, either of the above, because on pure imaging, while the index of suspicion for malignancy is high, you can't really tell what it is unless you biopsied it. A 34-year-old lady comes with a 10-year history of recurrent. Okay, we've actually done this case, so I'm going to run through this. This was the lady with the ABPA that I showed yesterday in the CT on airways disease. And you see this extensive proximal central bronchiectasis. You see the mucoid impaction that's hyperdense. That is characteristic of ABPA in the setting where you have asthma, which I haven't put in here, but that's essentially what you would have. So we're going to skip this. And for all of those who were there yesterday, you saw this entire case in detail. But we will look at this one last case and then move on to the musculoskeletal for about 15 to 20 minutes. This is a 70-year-old lady who presented with increasing breathlessness and cough. That's the HRCT image, that's the contrast axial study. That's the axial image again here, that's the contrast enhanced study. That's the axial image here and the contrast enhanced study. I got this wrong, and I hate myself for it, because this was staring in my eyes, and for some reason where I got sidetracked into believing what it was, I just got this completely out. So that's the axial with contrast, that's the axial with contrast, that's the coronal with contrast. These are your choices: bronchoalveolar carcinoma, Boop pattern, lymphoma, and lipoid pneumonia, and your time starts now. Images, axial, coronal. 70-year-old lady with increasing breathlessness and cough. Right. And so I don't feel bad about this at all, because that's essentially what happened. I looked at this, This is gradually progressive breathlessness. You've got consolidation, you've got ground glass attenuation, you've got a little bit on, ground glass spread size. So that's bronchoalveolar carcinoma, classic, nothing else. Looks like this, it's spread all over. I have residents in my place, and somebody asked me, why is there so much low density here? If you look at the coronal, it actually stares at you here as well. And I said, you can have low density in bronchoalveolar carcinoma as well. So I'm very trigger happy with my needle. So I went ahead, did a core biopsy, and if anyone can read this histopath, it's staring in your eyes. So I guess the point is to look at all of this. Anyone, what is this? It's fat. This was lipoid pneumonia. And again, it's because nobody gives you the story. So we called the daughter. The daughter is a very hyperactive, caring, so-called individual. And when we kind of asked her, does your mother do anything that could cause lipoid pneumonia? And then she says, she's been taking castor oil for the last 30 years for constipation. And so clearly the castor oil was getting aspirated. And then we told her, good news, she's got lipoid pneumonia, it's because of the castor oil. And she says, no, it can't be. My mom can't have something so simple. We said, no, it's not. She doesn't have cancer, she doesn't have lymphoma. No, it's not possible. She has to have something that means something, that has to have some weight in it. She took 5 different opinions. She would go from one chest physician to one oncologist to another oncologist. Unfortunately, all of them would call me back and say, what do we do with this lady? Because you've said it's lipoid pneumonia, we have it histopath proven, but she wants another diagnosis so that she's satisfied that it's not just fat collected in the lungs. Sometimes it's impossible to predict how people would behave. But nevertheless, the clue here on the imaging is the low density. The problem is, if I see another similar case again, I'm not quite sure whether I would not biopsy this to prove it one way or the other. The point is, if I had thought of lipoid pneumonia and biopsied it and it turned out to be lipoid pneumonia, I'd be happy. The problem is I thought of bronchoalveolar carcinoma without a differential diagnosis and it turned out to be something else. So nevertheless, that's as far as the chest is concerned. We'll move on to, we have only 15 minutes, so we're going to have to really move fast on the MSK stuff. Any quick questions on what we've done so far? Okay. 16-year-old with recent onset leg pain and swelling. This is the radiograph. That's the tibia, frontal, lateral. That's the MR, axial T2, coronal T2 or stir, doesn't matter. And these are your choices: osteosarcoma, osteomyelitis, giant cell tumor, and aneurysmal bone cyst. I run through them again. Plain radiographs, frontal, lateral, MR. Your time starts now. OGS, osteomyelitis, GCT, and ABC. So we need to run through this, don't we? Wide zone of transition, therefore this is an aggressive lesion. Aggressive lesions can be infection, can be malignant, but we've got new bone formation. We've actually seen extra new bone that is present within the lesion. And I mentioned that day before that a better way of understanding osteoid is to actually see the presence, or to use the phrase new bone formation. So a patient with osteomyelitis would not have additional, you would have the sclerosis that you see here, but you wouldn't have the new bone that you have here. On an MR, all osteomyelitis would show bright stuff on T2 because of the abscess formation. And even granulation tissue doesn't show this kind of low signal that we have here. These findings obviously do not represent giant cell tumor because this is an immature skeleton. Aneurysmal bone cyst is an osteolytic lesion with trabeculae. So those two are out. It's really between osteomyelitis and osteosarcoma but this is pretty much a spot diagnosis for osteosarcoma. 32-year-old comes with long-standing thigh pain and swelling. The long-standing is in the range of about 5 to 8 years, right? Long-standing thigh pain and swelling. That's the radiograph. It's a lateral through the thigh and femur. That's a T2 weighted axial, and this is a T1 weighted axial. You'll see here there are no fat suppressed images anywhere because they really create an issue when we're interpreting these. So a radiograph, T2 axial, T1 axial, and these are your choices. Soft tissue sarcoma, abscess, venous vascular malformation, and myositis ossificans. Images again, and your choices. Your time starts now. 5 to 8 year history, radiograph with the axial images. Yes, so the majority got that right. The history obviously is very critical. You don't have a soft tissue sarcoma that would be growing for 8 years in about 99% of cases, but once in a rare while you get that. An abscess is not going to be around for 5 to 8 years. This myositis ossificans doesn't look like this, but the clue here, number one, we see phlebolytics, which if we pick those up, then you have a diagnosis. And on the T1 weighted images, we have fat within the lesion. When we have fat within the lesion, it's always benign. That's pretty much the rule with soft tissue lesions. And even if you were to see this over a short duration of symptoms, the presence of fat within a soft tissue lesion, the presence of fat even in a bone lesion would tell you that it's non-malignant. You typically get that with osteomyelitis or infarction. And here too, when you see fat within the lesion, within the interstices of the muscle that is involved, it's almost always a venous vascular malformation. 45-year-old with gradually progressive swelling in the proximal forearm. Here again, the gradually progressive is over a couple of years. So 45-year-old, gradually progressive swelling, that's the T1 axial, that's the STIR sagittal. T1 axial, STIR sagittal, very simple and straightforward. One of those cases that we could get 100% on. Soft tissue sarcoma, lipoma, venous vascular malformation, and neuroma. These are your choices. The images again, T1 axial, STIR sagittal, gradually progressive over 2 years, and these are your choices. Your time starts now. So we should hit like at least 99% on this. So the idea is if you don't know, don't press. Sorry. Okay. So 77%. Again, the history. So venous all of these except for soft tissue sarcoma from a history perspective would not, would be possible. But if you see the T1, you've got fat. The entire lesion is fat containing, so that becomes a lipoma. I did mention that when you see fat within a lesion, it's invariably benign. And then I spoke about it in the context of venous vascular malformation, but that streaky fat within an otherwise bright-looking lesion on T2. And here you have a STIR that completely suppresses the fat, proving that it's fat and not blood. And that pretty much is a lipoma, and there's no other differential in this particular situation. All right, 39-year-old with focal swelling in the proximal leg. 39-year-old, focal swelling, proximal leg. That's a T1 sagittal, that's a T2 axial. Again, a couple of signs here that are quite characteristic of what the possibilities might be. These are our choices: soft tissue sarcoma, lipoma, fibroma, and neuroma. T1 sag, T2 axial, 4 choices, and the time starts now. T1 sag, T2 axial, and 4 choices. So what happens with soft tissue neoplasms is in the vast majority of them you don't have an answer. You assume all of them to be sarcoma unless proven otherwise. But you have 4 or 5 tumors like this one, the previous venous vascular, or the lipoma, and sometimes giant cell tumor of tendon sheath, myositis, where you may be able to make a definitive diagnosis. Now, if you see the lesion here, it's hanging by a stalk, right? You can actually see this thickened thing on which this is hanging. And so the thickened thing on which this is hanging should be the nerve. You actually see a split fat sign that suggests a very slow growing lesion. There is central low signal with the rest of the lesion being high signal that normally suggests a certain amount of low signal myxoid degeneration, again quite characteristic of a neurogenic tumor. So we've got it, the thickened nerve from which the lesion is hanging, as well as this particular appearance of low signal on the T2 weighted image. All of this suggests a neurogenic tumor. Very difficult to differentiate schwannoma from neurofibroma, and honestly, it's not really that relevant. So that's just a neuroma. 12-year-old with right hip pain, that's the radiograph. 12-year-old, right hip pain, that's the radiograph. That's the frog leg view. That's the frontal, that's the frog leg, right hip pain. These are your choices: chondroblastoma, osteomyelitis, osteoblastoma, and a non-ossifying fibroma. Frontal, frog leg, and these are your 4 choices. Your time starts now. Frontal, frog leg, right hip pain, 12-year-old, and these are your choices. Great, so at least 55% got that right. So on the frontal, at least today, in today's day and age, the vast majority of radiologists wouldn't be able to tell which is the abnormal side as well. And this is a worldwide phenomenon that I'm sure you've heard of the disease called hyposcilia, which is the reduction in clinical skills with the passage of time. It applies to individuals, but it applies to generations as well. And except for rheumatologists, radiologists and orthopedic surgeons alike, as more and more residents pass out, the ability to read bone radiographs is consistently, exponentially reducing. It's just the way it is. There's no good or bad. It's just a fact statement. And my father's a radiologist, and people like him in their 70s are actually becoming more and more important because they have the skill sets to read radiographs as well. But nevertheless, you do have osteopenia. That should tell us that the right hip is abnormal and the sclerosis along the lesser tuberosity. In a 12-year-old, when we see this, the first diagnosis that would come up would be that of an osteoblastoma. Chondroblastoma presents as a focal osteolytic lesion. Osteomyelitis is always a possibility, but a non-ossifying fibroma has a different look. But if we look carefully on the frog leg, we actually see the osteolytic lesion with the sclerosis and the cortical thickening. There's actually remodeling of the metaphysis as well. The MR here shows the osteolytic lesion with the central calcification, the extensive reactive marrow edema, and the effusion, and the CT scan again is very, very characteristic of the osteoblastoma. But this is an X-ray diagnosis in this particular case, only to be confirmed with a CT if the index of suspicion is high. So that's an osteoblastoma. 18-year-old with a left hip pain. And again, I mentioned the side because I never used to. I've been doing these ARSs for some time, and I would just say hip pain without saying right or left, and that is when I realized that it gets a little difficult. So nevertheless, this is left hip pain. There is a lesion that we see here, and these are your choices: chondroblastoma, osteomyelitis, osteoblastoma, and giant cell tumor. So not only do you have to identify the lesion, you need to actually be able to say which one this is. And your time starts now. That's the radiograph: left hip, chondroblastoma, osteomyelitis, osteoblastoma, and giant cell tumor. That's brilliant, 75%. So not only did we identify the lesion, and it's very well seen here, it's an osteolytic lesion in the head, it's in the epiphysis with a sclerotic rim. A giant cell tumor, when it presents, is never this small. An osteoid osteoma is not an epiphyseal lesion. Osteomyelitis doesn't present with a sclerotic rim. So an epiphyseal lesion with a sclerotic rim is always a chondroblastoma. Again, it's a benign aggressive lesion. You can see the extensive marrow edema created by this lesion that shows a very characteristic lobulated hyperintensity on the STIR image. There is effusion as well. You can see the T2 coronal, the post-contrast study, a little bit of the synovial hypertrophy created as part of the reaction that this benign aggressive lesion has, but very, very characteristic of a chondroblastoma. We now RFA these. So if a patient has a difficult to reach, the surgery for this would have reasonable morbidity. A radiofrequency ablation at the most would have the possibility of chondrolysis. So now when we have lesions less than 20 millimeters in size, we typically do a radiofrequency ablation, and the results have been very good. There isn't significant data, it's all anecdotal, but the largest series now extends to about 30 cases, and we do this quite often. So I've done about 10 or 12 of them already. Okay, 20-year-old with lower thigh pain and swelling. And this is a spot diagnosis, provided you've seen it once before. A 20-year-old with lower thigh pain and swelling, and that's the radiograph that shows this. Like I said, spot, if you've seen it before, you'd never forget it again, because it's so stark and so startling, right? I mean, it's not something you would forget easily. These are your choices: giant cell tumor, aneurysmal bone cyst, myositis ossificans, and a surface OGS. The frontal, the lateral, and that's the one. Your time starts now. And that is amazing. 60% of people got this right. It's absolutely brilliant. So here's what we have. We have a trabeculated surface lesion with an extremely thick, unbroken cortex. This is a benign lesion. Giant cell tumor does not present as a surface lesion, and an osteosarcoma, I mean, you have periosteal and parosteal. Parosteal is solid bone. Periosteal is a highly destructive, high-grade malignant lesion. Neither of this fits in. So really stuck with myositis and surface ABC. And what you really need to know is that about 15 to 20% of all aneurysmal bone cysts are surface ABCs. They're either cortical or they're subperiosteal. And when they are subperiosteal, this is what they do. When you have a T2 axial and shows you fluid levels that are completely occupying the entire ABC, then the lesion, then it is an aneurysmal bone cyst. A myositis typically would have a zoning phenomenon on the radiograph with a lamellated appearance, and again would not be contiguous with the cortex. It would actually have a convexity here, even if it is a surface myositis. So this is a subperiosteal or a periosteal lesion, and then you have the fluid levels. All of you would be aware that you can get fluid levels in other conditions like clear cell chondrosarcoma, telangiectatic osteosarcoma, etc. And the way to kind of convince yourself that this is an ABC and not the other kind of tumors is to look at the length of the fluid level. If the fluid levels occupy the entire lesion with nothing else, no solid component, no other kind of tissue within, then it's an ABC. If you have anything else apart from the fluid levels, or the fluid levels don't traverse the entire length of the lesion, then we have to think of alternative diagnosis. So this is a subperiosteal, ABC. All of you should pat yourselves on your back, because I didn't get it the first time I saw this about 8 or 10 years ago, and now of course it's kind of seared in my brain, and I didn't get it in an open forum like this where we're doing an orthoradiopatho meeting, and I kind of made a fool of myself in the presence of about 200 orthopedic surgeons. So you never forget that. They don't let you forget it as well. So, a 13-year-old with recent onset pain and swelling in the thigh. 13-year-old with recent onset pain and swelling in the thigh. Again, these are the kind of cases where today's parents, with helicopter moms, hovering around the children all the time, and stressed out fathers who want instantaneous diagnoses, would make you do things that perhaps you may not have done. So 13-year-old with recent onset pain and swelling in the thigh, that's the radiograph. There is a very subtle sign here. You need to be able to pick that up. That's the MR, because the MR gets done anyway, and that's the T1, the post-contrast images, and then a biopsy. The MR was done post-biopsy because there was a palpable swelling. You can actually see the defect of the biopsy here. These are your choices: soft tissue sarcoma, myositis ossificans, pyomyositis, and fibromatosis. And I'll run through this again. That's your radiograph. It's acute onset. This is the MR. Very, very aggressive looking lesion. Lots of edema, little heterogeneous, involving the muscle. But you do see a little bit of kind of a split fat here. And that's your choice. Time starts now. Soft tissue sarcoma, myositis ossificans, pyomyositis, and fibromatosis. Do let me know when we can stop, because I've already done by a minute.
We can just have one more case.
Yeah, so we'll do one more and we're done. Okay, and so this is why obviously somebody raised the possibility of soft tissue sarcoma, and that's how the biopsy was done. Honestly speaking, if this is a soft tissue sarcoma, waiting for 2 or 3 weeks is not going to change the prognosis. But there was something on the radiograph that made a difference. There was this subtle calcification or increased density seen within the lesion. Now this could be calcification in synovial sarcoma as well. We all know that you get speckled calcification within a soft tissue sarcoma, but this is too aggressive for sarcoma. A soft tissue sarcoma rarely has this extent of edema. Not only that, you will not find displacement of fat planes, you'll find infiltration of fat planes. So despite the edema, you've actually got the fat plane maintained on the T1 weighted image. This in a young patient would be highly suggestive of myositis ossificans. And if you were to wait just for 2 to 3 weeks, the lesion would evolve and change, and that's the radiograph after 3 weeks. That is what it was. The histopathologist got it wrong because there was some osteoid within, but having said that, since things didn't fit, they were thinking of an extraskeletal osteosarcoma, and none of this made sense. So when we looked at it with the pathologist and the orthopedic oncologist and all of us together, we obviously were about 10 to 12 days into the lesion, and we said, hold on, because none of this makes sense, and myositis is a very strong possibility. 3 weeks later, you have the classic appearance of a myositis, and that's all there was to it. So whenever we see a patient who has a very aggressive looking lesion, young, with edema but maintained fat planes, this is something that we should be thinking of. And I'm done. Thank you for your attention.
Thank you very much, Dr. Bound, for this nice presentation. Thank you.
So just before I leave, I have to rush to catch a flight, and I've just had a wonderful 3 days. I've put on about 2 kilos of weight thanks to all these people, who've made sure that we we can't escape the lunches and the dinners and the breakfasts and everything. But like to thank everyone in the organizing team, starting from Shafiq to everyone. Y'all have been wonderful. Thank you so much for a terrific time, and all my colleagues who, you know, Manu I've known for donkey's years, but Tony and Erica, it's been a pleasure, you know, sharing the tables with you all, and the podium as well, and the audience. Y'all have been wonderful. Had a great time in this lovely city of yours, and thank you so much.
Thank you, Dr. Bowen. Thank you very much.